Hi, everyone. Thank you so much for joining us early. We will get started in a few minutes. I ask that you take this time to please introduce yourself, your credentials, and your practice or organization in the chat. This just gives us a better idea of who's online with us today, and it also helps you access the chat before we get started. Hi, everyone. Thank you for joining us. We will get started in just a few minutes. Please take this time to introduce yourself in the chat. Please include your name, credentials, what organization you're with, and thank you to those who have already done so. Hi, Dr. Welsh.
Hey, guys. This is the first time using WebEx.
Are you using a new computer?
Not, it is pretty new, actually. Forgot.
I think we're going to have to make a switch in the summer anyways, so you don't have to get too used to it.
We're switching to WebEx, right?
We are being phased out. I don't know if we're a different department than you. Are you psych?
Yeah.
As far as I know, we're being phased out.
To what?
They're encouraging us to use Teams webinars, but we're comparing a couple different options.
I thought Zoom was being phased out.
That is concerning though, because I've heard other people in the psych department say that too. So I'll have to follow up with Dave on that. Feel free to pull your slides up whenever you're ready. No rush, I'll still do all of our introductions and everything. Thank you all for joining a few minutes early. We'll get started shortly, but please take this time to introduce yourselves, include your credentials and your practice. I see a lot of you have, and we really appreciate that. That just helps us get a better understanding of who's online, and you may be able to make some other professional connections. I'll get started with some housekeeping before we jump into the presentation, but as you may have noticed, your microphones and cameras are disabled so that we can accommodate a larger audience today. Dr. Welsh, I am seeing the entire PowerPoint application. There we go. Perfect. All right, the time is now noon, so I am going to go ahead and get started. This webinar is being recorded and will be available on our website within 1 to 2 business weeks. We will also have a link sent to you and any follow-up emails. So thank you all for joining us for today's webinar. If you have not joined a Max webinar in a while, or this is your first Max webinar with us, you may have noticed that the registration process has changed and we now use a learning management system called Oasis. So I've included the Max Oasis portal link in the reminder email. I'll also include it in the follow-up emails. That's really important because that's where you're going to be able to access the slides, the evaluation survey, other Max resources, and your certificate once you do complete all of that. If you are a nurse practitioner, advanced practicing nurse, or any other member of the healthcare team, you will be able to access your certificate after that evaluation survey. I will have to manually go in and verify your attendance, but that should be done by the end of the week at the latest. If you are a medical doctor or doctor of osteopathic medicine, your information will be entered into the ACCME passport within 60 days. Our accreditors do have a little more time to do that, just so we can ensure that everyone who needs to fill out the survey does, because all of that information is put out at once. I know that is a little bit of a change in the process, so please look out for those reminder emails and follow-up emails. Those will include all of that information. I'll also put a link to the portal in the chat so that you can, it looks like Marcielle actually did, which is great. So definitely make sure that you bookmark that link so you can always access our portal. As you may have noticed, today's webinar is being presented by the Maryland Addiction Consultation Service, but more specifically Max for Moms, which stands for Maternal Opioid Misuse. So those are all of the services that Max offers, but specifically for maternal health providers, anyone seeing pregnant patients or patients in any antenatal stage. So we are here to support prescribers and their practices, pharmacists and healthcare teams in addressing the needs of patients with substance use disorders and chronic pain management. All of our services are completely free, and they include a consultation warm line open Monday through Friday, 9 a.m. to 5 p.m. And you can call that warm line with clinical questions, questions about resources or referral information. Even if you want to talk through a case, as long as you're giving us de-identified information, you can get as specific as you'd like, and then you'll be connected to the appropriate consultant to follow up with you. So our behavioral health consultant will answer that phone, screen, kind of look what you're looking for, and then connect you with the right resources. We also offer education similar to today's webinars. We try to hold them 12 to 1 to accommodate your busy schedules within the lunch break. We also offer longer trainings, including half and half buprenorphine trainings to knock out that 8-hour MATE Act addiction training requirement all at once. So look out for that. Make sure that you are signed up for our newsletter. That's where we include all of those resources. We also offer technical assistance, which is individualized capacity building to practices implementing or expanding office-based substance use services. So what that means is if you are looking to get everyone on your practice on the same page about protocols, dosing starting off, anything like that, you can call us and we'll set up a TA project for you. Similar to a webinar and similar to all of these free credits, we also offer echo clinics, and echo clinics are collaborative medical education through didactic presentations and case-based learning. And what that means is someone like you or someone else from the medical community would come with a case, once again de-identified, present that to the audience, and then get feedback both from their peers and our panel of consultants. And that's followed by a short didactic presentation on varying topics. We do have a Max for Moms specific echo, and I'll make sure that that information is included in the chat as well. And then I do want to go over something important that a recent change. There was an announcement recently that updated prescriber enrollment requirements for behavioral health practitioners are changing. So to comply with federal regulations, changes are being implemented by the Maryland Medicaid program related to reimbursement for prescribed medications. It says effective July 1st, 2024, but there are steps that need to be completed by April 15th, 2024. So please look out for that information in the chat. That'll be entered as well. If you have questions about these changes, it is a lot. Please review that and then feel free to give us a call. Definitely call the state and tap into them as a resource, but we are here to support you. So those are important changes. Definitely look out for that. And once again, make sure you're signed up for our newsletter because that includes even more in-depth information about that. Finally, I do just want to introduce our speaker today. Our speaker today is Dr. Chris Welsh, and Dr. Welsh is an associate professor in the Department of Psychiatry at the University of Maryland School of Medicine. He's also the medical director of the UMMC Substance Abuse Consultation Service. He's the medical director of the UMMC Outpatient Addiction Treatment Services and the medical director of Maryland Center of Excellence on Problem Gambling. Dr. Welsh is the medical director of our Max for Moms program. He's a great example of who you would be connected to when you do call that warm line or reach out to us for help. He also works with the Baltimore City Department of Health and the State Department of Health on expansion of treatment for opioid use disorders, needle exchange, opioid overdose prevention, and other harm reduction initiatives. Definitely tap into Dr. Welsh. Please utilize the chat to put in questions today. You will not be able to unmute or turn on your camera, so that's how you can communicate with us today, and I'll make sure that I communicate those to Dr. Welsh at the end of today's talk. Dr. Welsh, thank you so much for presenting, and please take it over from here.
Okay. All right. So let me know if my voice starts fading because I have a cold. So it's also the first time I think using WebEx for this. Hopefully there's no quirks. So what we're going to do today is just review some of the newer kind of drugs, and we'll focus on a few that I think are a little bit more in the news recently. Obviously, this is for Max for Moms, so where I could, I'll talk a little bit about what we know as far as pregnancy, lactation, those kind of things. But as you can see, a lot of these drugs are very new and things that there isn't even very much research on yet. So I don't have any conflicts of interest. So just a little bit of background of talking about kind of newer and different than the kind of more classic drugs. You'll hear a bunch of different terms used. One that some people might be familiar with is designer drugs, which really goes back to the 1980s when people were actually purposely synthesizing substances to kind of get around the Federal Controlled Substance Act to make things that were not going to be technically legal because they were different than the things that were illegal. You see there, that was a big issue in the 80s. They actually made a separate law then to try and address these newer, these new synthetic different drugs. But you'll see a lot of things we're going to talk about, they're even older drugs. They're just drugs that never became medications, different things like that. But they're not even necessarily things that were made specifically to get around the laws. Another term you're hearing a lot more nowadays is this, I mentioned it here a little bit, the new psychoactive substances, NPSs. again, a lot of them were made legitimately to try and make new medications at one point, and they never, for different reasons, just never were developed into a medication. Um, some of them actually were used for periods and then were pulled from the market. So again, this kind of lumps together a bunch of different things. Many of these substances have been synthesized, and there are only a handful that go on to become really popular. But again, it's important to know what's going on. So I like this slide just because it's even more of an issue now. So it's been an issue forever where even heroin, cocaine, the kind of classic drugs were often cut with other drugs. But nowadays, the people using drugs from the street and ones that they even think they're buying from legitimate sources, really people have no idea what's in them anymore. There used to be kind of more primitive ways of making counterfeit pills, but over the last 5 to 10 years, really sophisticated machinery has become available to these drug manufacturers that they make really you know good looking tablets and capsules. So people think that they're getting legitimate, say, oxycodone or Dilaudid or whatever it is, but it a lot of times it's not at all what they think they're buying. Also, just the kind of where people get their drugs. Here I'm at University of Maryland in West Baltimore, so most of the patients we see here still get their drugs from kind of street level dealers, but a lot more we're seeing, where we had that whole, in the late 90s till the last, it's still going on, but really big in the late 90s, early 2000s, where a lot of prescription drugs, especially opioids, were being misused. But now added to that is the dark web and people buying things that, again, they think they're legitimate. And we don't see, again, as much of this kind of here in West Baltimore, but a lot of other areas, people who are more computer savvy and they're going online and ordering, a lot of different drugs, like some of the ones we're going to talk about today, things that you wouldn't typically see kind of being sold as much kind of at the street level. So first, we're going to talk about different opioids. These are just some of the terms that are now being used. Non-pharmaceutical fentanyls, illicitly manufactured fentanyls. This was another one, fentanyl adulterated or substituted heroin, high potency synthetic opioids, a lot of different things here. We're going to talk about the different analogs of fentanyl. They're similar, but have differences in their chemistry that make them a little bit different. Um, some of these have been around for decades. We started seeing fentanyl analogs back in the 1970s. So again, this is a big issue now, but it's not really new. We've had it before. I like to show this was back in 92 here in Maryland specifically. We actually had a fentanyl outbreak then. So again, just reminders that, then if people remember back in 2006, there were some hot spots in the US that had fentanyl. Here in Maryland, we were one of those areas. But really what we're mostly talking about is what started around 2013. So the last 10, 11 years, where we started seeing the heroin supply. Initially, fentanyl was just being added to it, but it's really pretty much totally replaced it. And we think most areas of the country now don't have heroin anymore. It's all been replaced by fentanyl. And again, very important, there are people that misuse prescription fentanyl, but this is really not pharmaceutically made prescription fentanyl. This is being illicitly manufactured. Um, some of it here in the US. Originally, a lot of it was being manufactured in China. We had some crackdown on that. And so now, unfortunately, what's happening is a lot of the precursor chemicals are shipped in, usually from China to Mexico, and then it's being manufactured actually there. Um, just going to highlight, because I said there are a few dozen different types of fentanyl or analogs of fentanyl. One that people may have heard about, this one called carfentanil, which is very, very potent. It's actually used medically in veterinary medicine for like large like animals like elephants. It's so potent that small doses of it can even knock out an elephant. So very small doses can have somebody overdose and die. Um, so that's just one of the examples of the fentanyl analogs that are being used. Just to be aware, we're talking a lot about fentanyl, but there are some other opioids around. I don't know if people have heard of this. It's called ISO. It's one of a group that we'll talk a little bit more about that are called nitazines. There's another one that people call pink. It's just, really, again, it never was a medicine that was being made into a medicine, just never kind of progressed. And um, kind of the recipe for it sat around for decades, and then somebody a few years ago kind of found it and started making this illicitly. Then the third big one here is called morphine. Again, we're going to talk a little bit more about all these, but these are not fentanyl. They're not, like if you test for them, they don't come up as fentanyl, but they're new synthetic opioids that are also in the street drug supply now. I mentioned the one pink. Again, it was synthesized years ago, and it just never was developed into a medicine. And then, probably about 10 years ago, somebody started making it. And this is a screenshot from, from a website on the dark web where you can go on and you think you're ordering it. Again, there's no quality control over what you're actually getting mailed, but I mentioned this other group of opioids called the nitazines. So they were synthesized even longer ago, back in the 1950s. Again, they never really were developed into commercial use medications. There are a bunch of them. Some of them are more potent than fentanyl. Some of them are about the same. There's a whole debate over like if somebody overdoses on these other opioids, is it similar to fentanyl? How much naloxone does somebody need to reverse the overdose? Um, a bunch of them were, I don't know if people are aware, in the US, the Drug Enforcement Administration schedules medicines in Schedule 1 through 5. And schedules 2 through 5 are things that we can prescribe and we use medically. Like 2 is all the stimulants, all the opioids. 3s are some like Suboxone, and 4s are benzodiazepines and some other things. Schedule 1s are the ones that are not used medically, or that's what we think of as being illegal. So a bunch of these nitazines were already made illegal in the US. And then back in 2020, when we started to see more of them, the US government kind of emergently scheduled the rest of them. So, like I said, they're not used medically anywhere, but they're being synthesized and put in the street opiate supply. The biggest one that people are seeing is the one isotonizine, that we started seeing around 2019. Other parts of the country are seeing more of this. The Midwest is where it seems to have started. It's kind of spreading, but we seem to be seeing more of it here on the East Coast. And if anyone's interested, it's just showing some of the different chemical structures of them. And then that other one I mentioned, morphine. So that's a newer one. That was, a similar drug was synthesized in the 60s, but morphine itself seems to be synthesized back around 2018. And again, it doesn't need to be, but sometimes it turns out purple. And so there are reports of this purple heroin being around. And that just because it's purple doesn't even mean it's morphine. It could be something else in there, but there are different parts of the country that started seeing this for about 2019, 2020, people selling it as purple heroin. Um, It's a little bit closer to fentanyl than like the nitazines are, but again, it's still not fentanyl. It still isn't going to turn up positive on a drug test as fentanyl. It's kind of similar to fentanyl as far as how potent it is, how much of it you have to use to get an effect from it. You're seeing it, here, Canada, Sweden, Belgium. Again, it was other parts of the country that started seeing it, but again, the DEA is finding it in this area as well now. And it can also have down here, this is just it can have effect on your heart's conduction. It can make some people have arrhythmias, which is pretty unique to opiates. Only methadone actually can sometimes do that, but that's something unique to this morphine. So just as far as these medicines or these drugs in pregnancy, there really none of them have been that well studied. Um, with fentanyl specifically, because that we do use medically. There's not a lot of people who are prescribed it chronically through a pregnancy, but there is some evidence, some studies with fentanyl specifically. It doesn't seem to have any different risks than other opioids as far as for the pregnant person or for the baby. But remember, all opioids, if the mother is taking them throughout pregnancy and develops physical dependence, the baby is also at risk for having physical dependence and having withdrawal at birth. So that doesn't seem to be any more or less than with other opioids, but it's the same. It is an opioid like other opioids, and so it is an issue to be worried about with the newborn. Very little of it is gets into the breast milk. So it's again like other opioids that it's something to be aware of, but isn't necessarily a reason to say not to breastfeed. And then as far as these newer, the nitazines, morphine, pink, there's absolutely no data on those. They're so new and they're so seldom tested for that even if somebody's using them in pregnancy, most of the time we don't know that they are because they're not things that we can like just test for in a clinic or in the hospital when somebody comes in. There are a handful of labs in the country that can test for these newer things. So again, they're just so new that we just don't know much about them. Something I just want to mention, because this is very different here in Maryland, and I'm not sure, what parts of the state people on the webinar are from, but if people have never heard of smoking heroin, that's something that was done starting back in the 90s, and it was really only done in the western part of the country. Um, because starting back in the 90s, most of our heroin came from Colombia, whereas most of the western part of the country's heroin came from Mexico. And Mexico made this black tar heroin, which is this tarry, gummy form of heroin that people would smoke by putting it on a piece of tinfoil. If people have ever heard of somebody talking about chasing the dragon, that's when you put the tar heroin on a piece of tinfoil, you hold a flame under it, and then you breathe in the smoke with a straw, like the woman there is doing. So that was really mostly done in the western part of the country. But then around 2010, as the prescription opioid epidemic was kind of starting to, get a little bit better, the Mexican drug cartels flooded all the areas that had the prescription opiate problems. They flooded them with their heroin. So we started to see tar heroin much further east, like in the Appalachia and areas like that. And then we started seeing smoking kind of creeping eastward like that. Um, so like I do, Suboxone by telemedicine to the jail in Allegheny County in Cumberland. Um, and even for the last 5 years, people were talking about smoking there because it had become, again, came into the Appalachian area. And so where it was more in like in West Virginia, that whole Western Pennsylvania there, it was also creeping into the really more Western part of Maryland, and also we're hearing about it in Southern Maryland. And what happened as the heroin was replaced by fentanyl, places that used to smoke tar heroin continued to smoke fentanyl. So they would just take the powder fentanyl and put it on a piece of tin foil and hold a flame under it and smoke it that same way. So if you're hearing about that, that's what people are talking about. I would say about 20% of the patients that I interview in the Allegheny County Detention Center smoke their fentanyl there. So we still haven't heard it coming a lot more further east, but I think it is going to. So just to be aware of this, and it's really not technically smoking. You're not lighting it on fire the way you do like a cigarette or marijuana. It's almost more like vaping. You're kind of superheating the tinfoil, and then the vapor comes up and you just breathe it in like that. So I just mentioned that because it does seem to be coming more eastward, and it's again just something we've really not had in Maryland before. This is just showing kind of nationally, there's been a big trend over the last few years of people that used to inject or sniff drugs now smoking them more. So I think again, it's just part of that same phenomena that the Mexican cartels have now pretty much taken over everything, and people are just smoking what's mostly fentanyl now, but they're smoking it the way they used to smoke tar. All right, we're frozen. All right. Another opioid, I'm not going to spend a lot of time on this, but if people have ever heard of this, it's called crocodile. Um, this actually, it's been around since the 1930s, but it's really been mostly in Russia and Eastern Europe. But we've had periods where it's kind of appeared here in the United States in the 2000s, and we haven't heard about a lot of it around here in Maryland. It's been in different pockets. It's often in areas where there's more of a Russian drug cartel involvement. So parts of New York actually have it, some places out further west. Um, it's actually really, it's using prescription opioids that have mostly codeine, which in a lot of countries is actually over the counter. And it's really just using solvents like gasoline to extract the codeine and then inject it. And it's known because people often get really bad wounds from it. And we're going to talk more about wounds associated with another drug soon. But sometimes when people start seeing these really bad wounds, that they think that this crocodile's around. So again, just to be aware, because people talk about it, but we don't think we have much of it around here now. Another drug to be aware of is kratom. That if people have heard about this, it's actually it's from a plant. You see, it grows mostly in Southeast Asia, and it's used. A lot of people use it kind of the way cocaine is sometimes used in Andes Mountains in South America. People will use, in some places like that, that's actually legal. Same with kratom, and we'll talk about its legality even here, but people use it for different reasons or different, it's associated with energy, with relaxation, a lot of different things, some of it depending on the kind of the strain of it and the strength of it. Um, just to be aware, there are a lot of different chemicals in it, but we think the main one, this mitragynine here, is one of the main ones that people use it for. It's actually similar to other hallucinogens like psilocybin, magic mushrooms, but it also people report stimulant effects. And what's important is that it seems to have opioid receptor effects. And if people aren't aware, we have a few different types of receptors. We usually think of the mu. That's the one where kind of the classic opioids work, where our pain really is. But there are other receptors called kappa receptors and delta receptors that are important for other things. And kratom seems to have effects in all of those. When people use it, the effects take like 20 to 30 minutes. They last for 2 to 5 hours. Lots of different side effects that people can have. Um, Rarely psychosis and other things are reported. But it's important to realize that it does seem to work on our mu opioid receptors, and that people can develop a similar withdrawal syndrome that you get from withdrawing from other opioids. So people definitely need to be treated sometimes the same way they would if they were using, heroin, fentanyl, one of the typical opioids. It's interesting that the US tried to make it illegal back in 2016, and it was actually such public outcry because a lot of people were using it illicitly. People wrote to their lawmakers, and actually it was the making it illegal was held. Some states have kind of separately banned it, but it's not illegal nationally. So here, like Maryland, Washington, D.C., it is not illegal. So you can go to, like different head shops, things like that, and buy it legally. As far as pregnancy, very limited data, mostly just based on case reports. It's hard because a lot of people use other substances, so it's very hard to kind of tease out what's attributable to one thing. There's no evidence of it causing birth defects. But like I said, it's sort of similar to other opioids in that there are definitely reports of mothers using it who themselves developed an opioid withdrawal syndrome, and the baby developed, a neonatal opioid withdrawal syndrome, NALS, that needed to be treated similar to if a mother were using heroin or fentanyl or another opioid. All right. So we can spend a little bit more time on this one because I think it's one that people are hearing about more in the news, xylazine. So again, this was synthesized, many decades ago. It works on our noradrenergic, our epinephrine system. Um, it's similar to other things that people might have heard of like clonidine or another drug that's used in the hospital called Precedex. Um, it's like other like phenothiazines. These are what some antipsychotics are like, and other older antidepressants. So it's a little bit of an odd drug. But it's mostly similar to these other things like clonidine. In the U.S., it's only used in veterinarian medicine. It's very, very sedating. So back when they were doing studies in humans, it was really sedating, and it was just hard to get a dose that could be used for humans without making them too sedated. So it's really only used in these animals, but it's actually used a lot for them in anesthesia as a muscle relaxant. And with the animals, it's usually given either in under the skin or in the muscle or even IV. There are actually reports of humans accidentally overdosing, like usually veterinarians or people who like raise horses when they're trying to administer it to their animals. Just showing here that it's these are some of the brands of what's available and how it's structurally similar to clonidine and other drugs. Misuse we started seeing again, or even going back in the 1970s, and then it was really mostly just veterinarians and people again who worked with horses who had access to it. Um, Started to see more kind of widespread illicit use in the 2000s, mostly in Puerto Rico, and then in the late 2000s started appearing in the U.S., mostly in the Philadelphia area. Um, Over the last 5 to 10 years, it's very gradually become kind of more an adulterant. Again, it seems to have started in Philadelphia and it kind of spread up and down from there in the mid-Atlantic, and then it's really spread to pretty much the rest of the country now. Um, Usually it's in with other opioids, but it's also being found now in with stimulants and other drugs as well. Um, People, debate why added. People think that it might help prolong the effects of fentanyl, the sedating effects especially. Um, might also help prevent the withdrawal from fentanyl, and it might also people think that if it's kind of if there's less fentanyl, so there's less of that very potent drug that that it's killing people, that it actually may be, it's sedating, but it actually may be helping with less respiratory depression than like a pure opioid would. So those are why people think that, you know, the drug manufacturers might be putting it in. Um, Usually it's a liquid what's used like in you know, for anesthesia with animals, and then it's like dehydrated into a powder that then is cut in with the other drugs. More and more, the precursors seem to be coming over from China and going directly to Mexico, where it's, you know, put in with the fentanyl. These are some of the kind of street terms you hear from it. Trank is a big one, Philly dope, because again, we think that's where it started. The vast majority of people using it, they're not seeking it out. It's just in the street drugs that they're buying. Um, there are people that like through like I mentioned, the dark web, or, you know, through kind of veterinary contacts do seek it out, but that's pretty rare. The vast majority of people that it's in their system, they're not looking for it. It's just cut into the drugs that they're buying. Um, Again, there may be smoking of it the same way that people are smoking, you know, the fentanyl. It has a pretty rapid onset within minutes, and its effects usually last about 8 hours, but there have been reports of it, especially some of the sedation lasting for even up to 72 hours. You're hearing more and more in the news about it being associated with fatal overdoses. The important thing to remember with this is that it's almost always cut in with fentanyl, which people die from anyways. So the vast majority of it isn't killing people by itself. It's just cut in with the fentanyl that's killing people. This is actually here in Maryland. We're pretty progressive. Our medical examiner has been looking at this, and just, you know, these were just some of the cases where people died with fentanyl and xylazine in their system. And even though they had xylazine, it was very minute amounts. So again, it's just showing that xylazine is in a lot of what's on the street now, and people are dying from it, but they're really dying from the fentanyl that's in there, or the, you know, the morphine or the ISO or whatever else is in there. The xylazine itself, we'll talk more about what that does, but it's probably not by itself killing people. Just gonna skip over. So just talk a little bit about xylazine intoxication. Um, like I said, it's very sedating, and and xylazine, like clonidine, affects blood pressure. So the person's blood pressure, heart rate can all go down. It doesn't have nearly as much effect on breathing as opioids do. But again, it can be very sedating. And there are also reports of it affecting blood sugar, and also in animals, at least, some reports of it affecting causing anemia. Um, it doesn't itself respond to naloxone, but if somebody has overdosed, you should give naloxone. Like I said, it's likely that if the xylazine's there, it was there with fentanyl or another opioid. So you still want to give naloxone, but the naloxone isn't going to reverse the xylazine itself. People will use other things again just to help with the sedation. They're looking at something that's used sometimes in animals. If somebody, you know, like if the animal has gotten too much to reverse it, but right now we don't have anything specifically for humans. As far as withdrawal, it's sort of, again, if somebody's taking something like clonidine chronically and stops it, they can also have withdrawal. And again, clonidine is a blood pressure medicine. So the biggest thing you're going to see is an increase in blood pressure, heart rate, people get sweaty, very similar to opioid withdrawal, because the same system, your adrenergic system, is involved with opioid withdrawal. So if somebody's using fentanyl that has xylazine cut in it, and they stop it suddenly, they're going to have both opioid withdrawal and xylazine withdrawal at the same time. So it's going to make their withdrawal even worse. And the typical things we use, like buprenorphine, methadone, to manage opioid withdrawal, they'll help with the opioid part, but they're not going to help as much with the others. So people may need other medicines like clonidine, that Precedex I mentioned. Um, there's not a lot of actual research on this yet because it's so new, but lots of places that are seeing a lot of this are saying that they really have to use like high doses of things like clonidine and Precedex to help manage the, all the blood pressure, heart rate issues that are happening when people are in withdrawal from both of them. And then the third thing to be aware of that I think people are hearing a lot about is the wounds that seem to be associated with xylazine. The vast majority of these, unfortunately, because not a lot of places can test for xylazine well, but we see a lot of we think worsening wounds that the xylazine might be involved with. People think it has to do with the same way that it lowers somebody's blood pressure, its effects on your blood vessels are kind of limiting oxygenated blood getting to certain areas. And so it makes it easier for a wound to develop. And then once a wound is developed, it makes it harder for the wound to heal because it's not getting, oxygen to help it heal as well as it should. So um, what's important, people that are seeing a lot of these wounds describe them as not as much like an infected wound necessarily, like you tend to get from other IV drug use, but certainly the wounds can also get infected. But a lot of these wounds are more or less like a burn, and so the management of them is more like managing burns than managing an infected wound. So these are just some kind of tips down here, but again, just to be aware that the xylazine, it seems to be in a lot of the drugs that are out on the street now. Again, people are not seeking it out, but we do have pregnant patients coming in who are using, the street fentanyl with xylazine in it, and some of them are developing these wounds as well. That's something to add on to having to manage with the pregnancy. As far as xylazine in pregnancy, almost all that's out there is in animals because that's where it's been used for decades, mostly cows, sheep, and mice. But it does seem to cause decreased uterine blood flow and also effects on heart rate, where it's pretty significant amount of lowered heart rate in the mother, less so in the fetus, but still. Can see some issues with vascular resistance in the uterus. And so it does seem, again, this is only in animals, but it does seem that there's is some association with decreased fetal growth. The big study look at that was complicated because they were also getting ketamine. But when we're looking at humans, again, practically no real data. It has been found in the umbilical cord, but it's a very small amount. It's not really clear what that means. Um, Clonidine, which again is similar but not the same drug, um, has been shown in some studies that it can also restrict growth. So again, we don't know a lot, but just to keep an eye out, and it, as we're seeing it more, and if it doesn't go away, then we're going to get more experience with it, and it's something just to keep more of an eye out on for now. Another drug that's been in the news more recently is it's called tianeptine. Some of the street terms for it there, Tiana, Tia, Jaja, and people are calling it gas station heroin. It's actually, up here, it's a used in a number of European and Asian countries as an antidepressant and anti-anxiety drug. It's never been approved here in the United States, but again, people are often getting it through the dark web. We started hearing about it back in 2000s, but it's been really the last 5 to 10 years where there's been somewhat of an increase, and I would say even just the last year or two where it's even more so that we're hearing about it. This is kind of what it comes in, and it's legal now. So people, you can go into gas stations and corner stores, and these are up on the market. They're marketed as a dietary supplement. They're not controlled by the FDA or the DEA. They seem to work on the, our opioid receptors, but they also work on serotonin. That's why they're used for depression and anxiety. They have some effects on our another system, the glutamate system. They're, kind of more complicated chemical. We're still trying to find out more how they really work, but they do seem to have effects at the mu opioid receptor. And there are more reports coming out of people um, having respiratory suppression the way you can from another opioid, or having withdrawal that needs to be managed kind of similarly to somebody withdrawing from other opioids. Just showing you kind of here the labeling that, and again, these are legal. So just showing you, they kind of sound pretty benign, but then, right here, there's the tianeptine in it. So again, a lot of people think, well, it's a dietary supplement. It can't be that dangerous. And so just to be aware that, that one, we just don't know a lot about it, but it seems to be becoming more common, and we're hearing about it more here in Maryland. Don't know a ton in pregnancy. Some case reports, it doesn't seem to cause birth defects. But there are, again, because it does seem to work on the opioid receptor, not as much as a full opioid does, but there are definitely reports of mothers and babies having withdrawal if they've been using this regularly and stop it, at birth. So again, just to keep that in mind if that's something you think you might be dealing with. Just real quickly to mention designer benzodiazepines. Some of these are truly designer, but a lot of times what they are is benzodiazepines that are just not available in the United States, but people are getting them again, often through the dark web, kind of shipped in and using them. So we definitely, they're the kind of Klonopin, Valium, Xanax, the kind of typical ones we have here, but there is a market for these um, either newer kind of totally illicitly manufactured ones, or ones that are manufactured and used mostly in Europe, but that are being brought into the United States illegally. But they're pretty much, they're benzodiazepines, so they're not there isn't really a fundamental difference as far as kind of clinically what to do about them. This is another one sometimes people hear about. It's called Phenibut. It's sort of like a benzodiazepine, but a little bit different. That is again from Eastern Europe, but is not illegal here. So people order it through the dark web. Another whole class of drugs that people may be more familiar, the psychedelic stimulants. So that's what the main one was, MDMA or ecstasy. These are still around. They're not, I'm putting this with new drugs because they kind of wax and wane in their popularity, but we're seeing more of them again. We're kind of running out of time, so I'm not going to spend a lot of time on this, but you just remember that, MDMA has been around for over 100 years and real popular back in the late 90s, 2000s, kind of waned, came back as a while later as Molly. Um, but again, they kind of come and go, but there seems to be a resurgence now of these kind of combination stimulant psychedelics that tends to be younger people and people who are getting pregnant. Most of the studies looking at this are not well controlled because a lot of people using MDMA and drugs like that are using other things as well. But does seem to be some association with some cardiovascular problems, low birth weight, and some even delayed motor development. And there have been studies especially in England, where they were popular back in the 90s and 2000s, where they did try and follow kids, and there was an association with mothers who had used, a significant amount, regularly through pregnancy, that it did seem to have some effect on motor development in the children. Just putting, because sometimes you'll hear about these. These are other drugs that are kind of like ecstasy or Molly. Smiles is one. There's another one, it's called bromo dragonfly because the chemical structure of it kind of looks like a dragonfly. Um, so these are all things that they kind of have. We don't see them much here in, kind of West Baltimore, but again, they're things that people tend to buy through the dark web. Tend to be, again, kind of people that are more computer savvy that are using them. Another group, things called piperazines that you may hear about. This one called benzofury is one of them. Real quickly, I'm just going to mention ketamine. Again, it's not new, but it's being used more medically, and we're seeing more of it getting out onto the illicit market. If people aren't aware, it's used now to treat, treatment, atypical and depression that hasn't responded to other things, but it's also just used a lot more in emergency rooms and other settings like that. So again, there's more of it around being used. It's also used a fair amount in veterinary medicine. Again, not a ton of research in humans, but it does cross the placenta and it does seem to have some effects on development, again, mostly in animal studies, but it is something to be aware of, again, if the mother might be using. People may hear about this. It's a new designer version of ketamine that people are calling Mexi and other things like that, that we're finding here in the US as well. Just real quickly, I know we're almost out of time, but I just want to talk about stimulants and focus on, because we're here in Maryland, we've always had a lot of cocaine and certainly more in the Baltimore area. But methamphetamine, we'll talk a little bit more about, prescription stimulants, and then there are other synthetic stimulants that are not methamphetamine, but they're also similar to these others, but a little bit different. I'm just going to skip over a little bit of this epidemiology. And what I really want to focus on the last few years, there's been a real resurgence of stimulants. And you have to remember, there's been stimulants around for, a few hundred years, but and stimulants and sedatives kind of go in waves of their popularity. Stimulants were huge, and especially methamphetamine in a lot of the country was really big in the 90s into the 2000s. And then the opioid epidemic kind of really just eclipsed that. But we're really starting to see a resurgence of um, methamphetamine, and it's a new kind of form of methamphetamine. It's a new chemical being used to synthesize it. It used to be Sudafed was the main chemical. That's why, it's behind the counter in pharmacies. But now there's this new P2P form that seems to be more dangerous, has more cardiac effects. And again, we're seeing a lot more of it across the country, but I'm partly putting this in because we're starting to see more of it here in Maryland. And it's kind of the same as I talked about the smoking of heroin and fentanyl in Western Maryland. Here in Maryland, kind of the further you get away from Baltimore, the more methamphetamine there is. And so Western, like again, when I do telemedicine with the Cumberland Jail, probably more people there use methamphetamine than cocaine. Same with Southern Maryland, Eastern Shore, Northeast, like Cecil County, because it's more popular up in the New Jersey, Delaware, and Pennsylvania. So they're seeing more. And this is just showing you here in Maryland, over the last few years, we're starting to see also more methamphetamine. So again, not nearly as much as we see other drugs, but it's definitely going up. So it's something to be aware, again, if there are people on this from other parts of the state, especially, definitely seeing more methamphetamine, and definitely might be seeing that in pregnancy. Just mentioning there are other stimulants out there. A big one is this group called cathinones. So they're not amphetamine, but they're sort of like amphetamine. And they were what, like back around in the early mid 2000 around 2008, we started seeing them and more people were using bath salts. That's the chemicals that were in them. Um, there's a newer one we started seeing more here in Maryland around 2019 called Utilone. Um, again, it's fairly similar to other stimulants like that. I don't know if anyone's heard of this. They're called trash can. So that what they refer to is this little plastic cylinder with a flip top, like like a household trash can. Started to see these right like in the end of 2019, right around COVID, and at the time there were other reports of what was in there. It can have all different things in it, but a lot of times they have these other stimulants, and a lot of them it's this other Utilone one. This is what I was already talking to about methamphetamine. Again, not new, but I'm talking about it more here because it is new to a lot of Maryland. And definitely now that we're seeing it more, it's just important to be aware of it. As far as stimulants in pregnancy, um, here the different ones, whether it's prescribed amphetamine like you would get in Adderall or methylphenidate, which is what's in Ritalin. Um, Again, not a lot of studies, but there is some evidence that it can lead to some organ malformation, and that might raise the risk for spontaneous abortion. Um, Again, just not well studied, but it is, again, just important as we're seeing more, um, just to be aware that it can be having effects on pregnancy. Just mention again, real briefly, these are not new, but they also come in waves, and we're seeing another kind of wave of these in a lot of parts of the area, the synthetic cannabinoids. They were kind of the first two were called Spice and K2, so that's what a lot of people just call the whole group of them. Um, we started to see them in the earlier 2000s, and like I said, they've kind of had waves of popularity over the last 2 decades. Um, but it's important to just realize, and they may be a lot less popular now because with cannabis being legal in Maryland now, but they really are different. They don't actually have THC in them, and they work on our brain's cannabis receptors, but they're actually, people don't realize THC is only a partial, stimulator of our cannabis receptors, whereas the synthetic cannabinoids are actually full stimulators of the receptors. So it's definitely around. Again, not maybe as popular as they were 10 years ago, but it is important to be aware of them. Um, we don't know a lot about them specifically in pregnancy, but it is important that our endogenous cannabinoid system is important in fetal development all the way from the embryo through um, you know through birth. So it's just important to be aware. And again, it's important with cannabis as well, um, but with these synthetic cannabinoids, because they are different, there's again not much studies, but some association with some craniofacial malformations, some issues in the development of your nervous system. So just to be aware. All right. So I know that was quick. I wanted to kind of just highlight, like I said, I spent a little bit more time on xylazine and tianeptine because I think they're the bigger ones that people are hearing about now. But if people have any quick questions, and again, you contact us through Max if you have questions or you want to hear more about this, or like I said, if you have patients that you think, again, now kind of the assumption is that most people, if they're using street opioids, it probably has xylazine in it. So we're just kind of assuming that now.
Thanks so much, Dr. Welsh. We do have a couple of questions in the chat. Before I get into those, I do just want to say you will receive a copy of the slides, so please look out for that via email and in the Max portal. The first question I'm seeing, and you may have addressed this, is xylazine picked up on a toxicology screen?
Yeah, so that's kind of complicated. Um, so xylazine can be tested for, and there are different types of toxicology screens. The main way of doing it is called an immunoassay, and that's what like most drug programs use, what most hospitals use. Um, Most places now that are testing for xylazine are actually places like syringe exchange programs and where they're actually taking a piece of the person's drug and they mix that in water and they put it on the drug test itself, and then they can test for xylazine. The problem is that when you ingest it and then it goes through your body and gets metabolized and all, it's much lower amounts of it. And so the tests that can detect it at those lower levels that we could use to test somebody's urine are really kind of very early in their being used. So it's theoretically possible, and certainly like it when someone dies, the medical examiner, they are testing for it. But it's very rarely now being tested in clinical settings, like in a hospital or in drug treatment programs, just because the testing is really so new and it's not sensitive enough yet to test it very well when it's gone through somebody's body. But you'll hear of more and more places that are testing the actual drugs that somebody's using.
Great, thank you. The only other question I'm seeing is, and you've definitely addressed this, it seems that the most important message is that there's not much useful data on the effects of these drugs on pregnancy and the newborn. Is that correct?
Yes, unfortunately. Almost all of them, it's either stuff from animals or, yeah, again, because it's so rare that somebody is only using one substance. So when we do have data from humans, it's just really hard to tease out what's from a specific drug. So, um, but but again, just more and more clinical experience, and especially like I said, xylazine, more and more, not necessarily with pregnancy, but certainly managing someone after they deliver, wouldn't be that different than managing a non-pregnant person. So as as we're just seeing more of it. Now, what I'm afraid of is that pretty soon fentanyl's going to be gone, morphine's going to be gone, ISO is going to be gone. There's going to be new opioids that are going to be in the drug supply that we don't know anything about. We're always a few years behind as far as what the drug suppliers are manufacturing.
That's a great example of something you can call Max about if you're seeing patterns with new substances or you have questions. We're always here to help you navigate those big changes. But all of our contact information is in the chat. Look out for those follow-up emails. Thank you all for sticking around for these extra couple of minutes. I'm not seeing any other questions, so I'm just going to save the chat and log off. But thank you so much, Dr. Welsh, for presenting. This is always a well-attended training. I know this is topical and people really have appreciated it.
Great. Thanks, everybody.